people that do the coding, in and pricing in healthcare, if you look after their names, there's always this alphabet soup of initials, or
Credentials. Yeah, right.
that tell you that they're qualified to actually speak in terms of coding and CPT codes and DRGs and those sorts of things. So having the ability to go back to those folks and talk to them about contract term, how that would play with the coding is essential in a direct contract. Almost as essential as the pricing, candidly.
Yeah.
And I agree with that too. I tell people oftentimes healthcare is the only industry that I'm familiar with where you go to school to learn how to drop a bill.
Welcome to ClaimTalk. My name is Danielle Young. I'm going to be your host today, and we are discussing direct contracting today. We have a couple of guests that have flown in to join us. You probably know Brad Hansen, but I'm going to let him introduce himself, and then I'll also let Jay and Shane introduce themselves, give a little bit of background. We'll get into our conversation.
Hi, I'm Brad Hansen. I'm the Vice President of Provider Relations here at ClaimTalk. Been with ClaimTalk for about 4 years.
I'm the president and CEO of the Kempton Group Administrators. We're a independent, family-owned, third-party administrator based in Oklahoma City. I've been doing this for about 34 years.
And I'm Shane Cerone, glad to be here today. I am the president and CEO of Kata Health. We are a management services and consulting firm. Most of the work that we do is we really help providers manage and organize themselves better and improve efficiencies. My background, though, is really as a hospital CEO, working for hospitals and health systems and medical groups around the country. And I've developed an interest over the years in the appropriate pricing of care and services to try and make healthcare more affordable. So I'm glad to be here today.
Makes you a friend of ours, right? Brad, do you want to just kick us off with a good definition of what a direct contract is in the context that we're talking about today?
Sure. When we talk about direct contracts at ClaimDoc, we're really referring to an agreement that's between the provider directly with the health plan. And so it may not be a part of any network or any traditional Blue Cross, United, Cigna sort of network, but rather it's negotiated between the folks actually with the employer, with the plan, representing the plan, and the provider directly. Sort of takes out the middleman.
Got it. And will you define also for our audience, just so we have good working terminology here, the different types of direct contracts that we engage in here at ClaimDoc?
Sure. ClaimDoc is a co-fiduciary. Any contract that we have is essentially and legally an agreement that's directly between the plan and the provider. And so we talk about them in the context of global agreements, which might deal with all patients coming anytime. Those traditionally look more like the traditional network agreements.
Right.
We also deal with single case agreements and single patient agreements that really are more one-off when it comes to the relationship with the provider and the patient.
Do you mind clarifying the difference? I'm asking legitimately because I don't know, between a single case agreement and a single patient agreement?
Single case agreement refers to an episode of care. So like a surgery and the care that is involved in the lead up and the post-op care for that one case. A single patient agreement might follow the patient through a series of episodes of care that's part of a treatment plan. So I think of a lot of times cancer patients have regular ongoing treatment needs. And so we'll negotiate with the provider to take care of that patient for like, say, a year.
Okay.
And that way we don't have to keep coming back every time there's another visit or another treatment that's associated with that treatment plan. And honestly, with a ClaimDoc, it really doesn't make any difference to us which of those three it is. We're happy to deal with the provider in any form or fashion that they want to deal with this on.
So Jay, talk to us a little bit about, in plans that you've put together and kind of managed over the years, situations where direct contracts have come into play maybe as like a core focus of the plan. Do you put together plans where direct contracting is like the number one play, number one go-to?
We do. The majority of our direct contracts, being from Oklahoma City, which is kind of the nexus of the free market bundled healthcare space. A lot of our direct contracts are, as Brad said, between the buyer and the seller, the health plan and the medical provider. But a lot of our agreements are also bundled from the medical provider's perspective to where it would include the entire unit of care, including the surgeon, the facility, an implant,
Anesthesiology.
anesthesiology,
Okay.
everything. So it's kind of like, buying a car at a car dealership. Tires are included, and exactly the out the door price. So we do a ton of that. And those agreements are in place and are repeatable, really across employer groups and also obviously across patients as well.
So in the context of contracting, I also wanted to sort of separate the difference between a narrow network and a traditional network. Is that something you want to tell us a little bit about, Jay? I know you
Sure.
have a lot of experience in that space.
Yeah. So as a third-party administrator, we're evaluating different network contracts, especially the rental network contracts, there's kind of a sliding scale, and I'm sure that you all are very familiar with that. Hospitals, they like it or not, they do tend to operate in a volume for discounts mode of operation. And so if they think that they're giving a discount to patients that they already have, the pencil is not going to get quite as sharp as it could be. What I mean by that is if there's a community that has 4 hospitals and your network has all 4 hospital systems in the network, you're asking that hospital to give a discount to a patient that they're likely to already see. A narrow network would be a network arrangement in where maybe you only had 2 of the 4 hospitals or 1 of the 4 hospitals. You would be, in the eyes of that hospital, you would be moving patients, steering them away from their competitors to them. They would get more volume and they'd be willing to offer more attractive pricing.
Yeah. Do you want to speak to that from a CEO perspective, Shane?
The narrow network side?
Yeah.
When I'm in the seat, whether it's interim or long-term, as the CEO of a hospital or health system, my view is that what's really challenging with the healthcare industry is that you can negotiate price concessions maybe based on volume. So this is where the narrow network concept comes in. But the real problem is that providers, in terms of big health systems, don't compete on price. And so the whole industry lacks what almost every other industry has, which is, as a hospital CEO, I'm not competing on price, but I might negotiate with you on volume, or I might not if I don't feel like it, if it's not big enough. The challenge that I see for narrow networks over the long haul is that no hospital is the best at everything they do always. I've had the privilege of working in some fantastic medical centers and academic systems and tertiary and quaternary centers. And what a lot of people just don't realize is a place that has a top 10 or 20 cardiovascular surgery program is one surgeon away from being a really good program, but not the best place for that procedure. And so where I see the difficulty with narrow networks for me, when I look at it through the lens of patients and then employers too, is that it can work a lot. It can work oftentimes, but it never feels right when a patient needs to be at a certain place with a certain physician because of legitimate, unique expertise. It's really hard to not let them go to those places. And so I think narrow networks are a tool. It's a way to get some price discounts for a whole swath of care that makes sense. But I worry for our industry over time that until we find a way to have meaningful price competition among major health systems and hospitals, that will constantly work around the edges, which is important. Those are important edges to work around, but it doesn't ever fix the rising cost of healthcare in this country as like a systemic problem.
Yeah, and and Shane brings up a really good point. It's sort of an argument against sort of just limiting the direct contracts to just the sort of traditional network agreements. That's why having more sort of one-off types of contracts available as part of the arsenal, it makes sense. So, for example, if we have a patient that needs cancer care in an area where, like MD Anderson or someplace like that, that's the best there is, right? So we want to have the ability to actually contract with them. Now, if you're limited to a network, you sort of get what you have in the network,
Right.
or you don't get what's not in the network, so to speak. So that's, to me, that's one of the arguments against sort of limiting it to the direct contracts to just a network sort of an agreement.
I think it's what keeps narrow networks from growing even
Right.
more than they have.
Right.
It limits kind of what they can do in the marketplace in terms of the penetrating the market to a certain extent.
Yep. Yep.
You talked about meaningful competition between healthcare systems. Do you want to elaborate on that a little bit more? What do you think is the impediment to like meaningful competition right now?
The impediment used to be, through most of my career as a hospital CEO, it would have been illegal for me to know what other hospitals in my city or region were being paid. It would have been anti-competitive for me to find that information. And so, for literally most of my career, that's what it was. When in the first term of President Trump, when the price transparency legislation was introduced, that's now changed that legal barrier that used to exist. So legally, you can get to the price information. Now, I think the significant barrier is the complexity. So to me, the problem with healthcare is the pricing mechanisms are so complex that it's hard for knowledgeable people to understand it and change it. It's nearly impossible for
Lay
the general consumer or an employer in I don't care what industry you're in, understanding healthcare. It's just so complicated. And the industry, we don't embrace a simplification of pricing. So I actually think percentage of Medicare kind of pricing models is an absolutely viable approach to creating a pricing mechanism so that the customer, the people who pay for care, the employers and the patients, can actually understand how much a knee replacement costs at X, Y, or Z. But I told a colleague and a friend of mine in Detroit who runs a big self-funded corporation that as a hospital CEO, we competitively price the things we buy all the time. Supplies, equipment, we get bids, there's competition. As a hospital CEO, health system CEO, I have never been asked to bid myself. I
You
do.
haven't taken a call from me yet.
That's still a two-party negotiation, though.
Oh.
What I'm talking about is we don't have a world where people are choosing the other system because I'm 30% more expensive. I don't care if it's milk, eggs, cars, and most any other products or services. When the consumer knows the price differential, they can start to choose with their feet. And that just really doesn't exist in the market today because of pricing complexity, is how I look at it.
That brings up another point that it's not only the complexity of the pricing, but also of what it is that you're going to price. And that's where an audit comes into play, or at least understanding how the coding works together and what should be paid and what shouldn't be paid. And that's what we call it, an audit. But that's a really big piece of a direct contract that if you're not in this world, live in this world, and spend your days in and out on coding, that's where you can really sort of miss the value of a direct contract. For example, people that do the coding, in pricing in healthcare, if you look after their names, there's always this alphabet soup of initials,
Credentials.
or
Yeah, right.
that tell you that they're qualified to actually speak in terms of coding and CPT codes and DRGs and those sorts of things. So having the ability to go back to those folks and talk to them about contract term, how that would play with the coding is essential in a direct contract. Almost as essential as the pricing, candidly.
Yeah.
And I agree with that too. I tell people oftentimes healthcare is the only industry that I'm familiar with where you go to school to learn how to drop a bill. Like, I can't think of any other industry where the billing department has special certifications and years of training before you would let them.
Yeah. And annual updates to learn and school.
Continuing education.
So complicated and technical, which
Yeah.
I don't know that you can get away from that, but it is a relatively unique feature of healthcare that adds to that complexity of understanding what things are going to cost.
Yeah.
This could be a little bit of an ignorant question, but do you think that insurance companies have contributed to the complexity? Do you think that insurance has caused that complexity, or do you think that the medical system itself sort of begot the complexity of the billing?
Boy, that's a chicken and egg
yeah.
sort of argument. I think it's probably both.
I think it's a symbiotic relationship.
Yeah.
They both win big by having the system complex. I certainly wouldn't disagree with Shane any about the complexity and how difficult it is, but I'm also a firm believer that it's complex by design. You just have to
Right.
look and see who wins and who loses. Keeping healthcare doesn't have to be complex. We've seen in the free market healthcare movement a growing number of facilities. Some of them are even hospitals that they're taking those more commodity surgeries and procedures, and they're again bundling them where they're pre-negotiating with their subcontractors, meaning the anesthesia, pathology, et cetera, to come up with a simple to compare unit of care. How much does it cost to have my hernia repaired? You should be able to get one price, and you should be able to get that one price preferably from the facility, and that would include all of the component pieces. I think in healthcare, we've all tried to figure out, well, how do we make the complex understandable? In any other industry, that's never the responsibility of the buyer. It's always the responsibility of the seller. If Apple made the iPhone where you had to buy all the component pieces, you had to buy the processor and you had to buy the screen differently, how many iPhones do you think they would sell? None. They have to make it simple to buy, simple to compare, because if they don't, you'll buy somewhere else. And the medical establishment, the cartel, as I like to refer to it, as long as they can keep the buyers disempowered, then they can write their own check, and they do.
I don't know that I see the insurance industry as intentionally driving a lot of the complexity. For me, a lot of the complexity comes from the coding and diagnostic systems that were put in place way back in the 80s when the federal system came up with here's how we'll pay for healthcare. And I don't think that that's necessarily bad. It's, people are not automobiles, and when we do repair work, it's very different than most other industries. So there's a complexity there that I think is unavoidable, and the CMS, Medicare, has a national system for how to come up with these codes and the like. Insurance companies mostly use that system or variations of it, in my view. I think the complexity for me comes into is the two-party negotiation process again, because if prices were set by the market in more of an open market type model, and insurance companies were basically serving in their function as TPAs to process the claims, I don't think we need nearly as many insurance companies as there are in the country. And so I think there's a threat there of like, if you gave up that complexity, the industry would simplify, and I think it would restructure quite a bit in a way that would pull cost out, in my view. So I don't see them as building it, but I don't know that a lot of them want to move away from it.
Nobody in this industry wants costs to come down, though, except for the buyer. That's the reality.
Yeah, I think that's true.
I think that's true. Yeah.
I mean, not in the free market kind of which is my point about we don't compete on prices. Yeah. When I run a hospital, I'm competing on a million things, but not pricing down the street because people don't understand it.
Mm-hmm. And regardless of how it got here, it's here, and the best, and it's our job as buyers,
proxy buyers,
to try to deal with it, right? And so Oklahoma City is a great example for the package pricing and bundling, going out and pulling all the different components together and saying, okay, a total knee costs X. And you can compare that to a total knee replacement in another market or within the market,
Indiana,
and decide where you want to go, right? But that's just, I would probably argue the bundling and the package pricing has just sort of scratched the surface. I mean, it's a handful of procedures when you look at the full array of care that patients need within a health plan. But I think you're absolutely right. I think there's less of an incentive on the provider and the insurer side of the table in getting rid of the complexity, because that's just kind of the
smoke screen,
right?
They need the smoke screen,
right.
to do their dastardly
So our job is
deeds
to get through the smoke screen and figure it out, right?
Yeah, I want to go back a little bit to kind of like the basic blocking and tackling of a direct contract, because, we always like to talk about the purpose of our podcast is really educational. We want people to feel educated and feel empowered because they have some knowledge. So if you don't mind, Brad, will you go through kind of like the important components of a direct contract? What are like really the functional organs of that?
Yeah, in some ways, a direct contract is no different than any other service agreement. You got pricing, you got terms, you got dates that line up, and methods to get out of the contract and ways to deal with the breach. Probably the two biggest components, obviously, the pricing. That's a huge part, right? Equally as important, though, are probably the terms that surround what it is that would be priced. And what do I mean by that? Really, are how you're going to handle different combinations of codes and services. And so if you use Medicare, and I always tell providers, we get it, Medicare is a complicated system, but it's a language that all providers speak. So if we
Common language.
it's a common language. It's like English in some ways, right?
That's right.
Really, really complicated, but
Very
At least we
difficult to
both know
learn,
what we're
but
talking
we
about.
know what we're talking about generally, right? So, and so having them talk in terms of Medicare also incorporates a lot of the rules that Medicare uses for how to bundle codes and what you really want to avoid, and you have to have some knowledge along the coding so that you don't pay for things twice. So a DRG includes all aspects of a episode of care that's inpatient, right? And so that would include all of the things that would normally go with that DRG.
will you define DRG really quick?
Diagnostic related group, and
Thank
that's
you.
how all hospitals are paid for inpatient care
Yep.
through Medicare.
Thank you.
And most other payers follow some variant of that as well. And so how you handle, if you ever look at your itemized bill, you see a long pages and pages of care that was provided. Which of those things should have been incorporated in the DRG, and which of those things would be above and beyond the DRG is part of that reimbursement science. And that's where a healthcare reimbursement agreement is very different than lots of other agreements. Maybe, I'm sure there are others that are equally complicated, but it's very complicated. And so you really have to have some background on that.
Yeah. Do you mind speaking a little bit, Jay, to how you've used direct contracting historically? Do you traditionally use direct contracting as like the core of a plan or as more of an ancillary fringe solution? How do you, or both?
Yeah, rarely would we ever do direct contracting as a core. Our core plan designs are either going to be reference-based pricing based or network-based.
Okay.
But I think it's an important distinction. If we are using a network, we will always use a network and/or negotiate with the network so they do not limit our ability to direct contract. And so what we tend to look at in either one of those environments is our direct contracted providers tend to be the ones that we try to steer patients to or navigate patients to because they're generally higher value medical providers. They're either bundled where they'll stand behind their outcome for a set price, or, I know you all in the ClaimTalk world are very familiar with this, or if you have a very noisy provider that is problematic, then of course you'll have a direct contract with them just to calm them down, especially if they're a provider that the employer group really, really needs or really desires.
Yeah. Do you mind speaking, Shane, a little bit to what the benefit of a direct contract might be to a hospital system as opposed to taking like a network agreement? Is there much of a benefit or is it kind of all the
I
same?
don't think I don't think people view it as a huge benefit unless there's an enormous number of lives packed behind it. I think
Okay.
it's usually more of a reluctant conversation than anything else.
Okay. Yeah, that goes back to what you were saying earlier about how you compete on volume as opposed to price.
It's also to a health system, I think it's a lot of work for, you can negotiate with a major insurance company and then things are in place and you see patients, you bill for services. As you get smaller and smaller to that central team, it's, more work for just a smaller group. But as a hospital CEO, when I'm sitting in that seat, I know very little about it. I've got a team of people working on it. I have a million other problems and challenges in addition to this, but I don't even think it oftentimes catches the radar of a CEO for sure.
Well,
in
I
most
don't want this to sound provocative or anything, but you're absolutely right. I always view that they're super reluctant to do that, and they would much rather have the big volume play. But I'd like to hear what your thoughts are, is because simultaneously you'll also have hospital systems that will complain about being leveraged by a particular payer. And it's like, yeah, but they have the biggest volume. You've made them the beast that now you're complaining about, while they will inflict financial damage on a local employer that's got 100 lives that are just trying to take care of their employees. So the hospital will target them for financial destruction while partnering with a large payer that then they complain about being leveraged by.
I mean, my personal view is that as a health system hospital CEO, I'm a nonprofit CEO. And part of what I'm, as I've moved along in my career, the things that bother me the most is the variability in pricing that exists. And it's massive. And most customers, self-funded employers, and for sure the patients, don't really understand. I mean, I grew up, near Omaha. I've spent some time in Iowa. I live in Detroit. It's incredible, the pricing differentials between what I would call Midwestern markets, just even along that section of the country.
I mean, even Michigan and Indiana, for example, very converse.
Very different.
Pricing, yeah.
So, the RAND Research Corporation, other places have done really good data sets. The national average is 240 or 50% of Medicare is the average payment to hospitals. And that's an average across with tremendous variability, not narrow variability on pricing, like tremendous variability. Some places are paid 3 times Medicare. In Detroit, we were paid closer to 1.5 times Medicare, which is among the lowest rates in the country. So I've personally worked in health systems that operate at 150, 160, 170% of Medicare. Most people are paying 200, 240. And these are, this is not a gallon of milk and not these are not small price items. That much price differential on things that cost $10, $20, $30, $80,000 for certain healthcare services is a tremendous cost to the employer. And so, I'm not going to defend that the small players, how much more they pay because they don't have those big bundles. But again, I think the nature of complaining about all the challenges exists unless we have price competition. That's why I say, we either have a free market or some people don't like it, or embrace a public market where prices are dictated like other countries, like Medicare does. And I'm not advocating for either, but to me, you have to have one. In my mind, you have to have one or the other, and we haven't embraced anything in there. I want to throw in, if I can, because it colors a lot of my conversations with people. When I talk in other forums and we talk about the cost of healthcare, I like to say, does everyone understand how much money we're really talking about here? And what I mean is, can we get to a common language around that? And I'd like to say the math that I've done, and I think it's correct, is I start globally and I look at the international statistics on the per capita cost of healthcare in the world. And most of us have seen these charts, and we all know the U.S. pays more per person than any other country in the world. But I say, well, let's look at the difference between the U.S., which is a little over $12,000, I think, as of a couple of years ago, dollars per capita, to the second most expensive country in the world, which I think is Switzerland, which is around $8,000 per capita. So in this country, we spend about 50% more than the second most expensive country in the world. And I tell people, if you take $4,000 and some dollars and you multiply it by the population of the United States at 330 some million, you come out somewhere north of $1.5 trillion difference. It's almost enough to plug the deficit last year that we're all angst up about. And a lot of that, not all of it, but a lot of that is in the variability in prices in this country. And yes, it does manifest the lack of competition. But yes, everyone goes for the best price they can get. And until we have a system that creates more competition, everyone will work toward the lowest price they can get or the highest price they can get if you're the provider. That's the system that we've created and that we live in. And that's what the challenge that I think organizations like yours are trying to get at and making probably meaningful dents. But there's a structural barrier that it wouldn't have to be this hard if there was more competition on open, transparent pricing among provider organizations. There's no reason to pay 230% of Medicare in Des Moines and 160% in Detroit. There's no rationale for it. And it's probably close to that kind of difference.
Wow. Yeah, that's really powerful perspective. Thank you so much, Shane. Hey, stick around, stay subscribed on whatever medium you're subscribed to our podcast. We do have a part 2 coming, so wait for that. Get ready to watch. We're going to get into more beef around direct contracts and healthcare costs. So we'll see you soon. Thanks.